Okay, so this presentation is dedicated to the evaluation of LV systolic function by echo. وطبعا الموضوع قد يطول أو يقصر يعتمد، ولكن أنا I'm going just to take you through the account of echo evaluation for LV systolic function and all the technologies used by echo or all the measures used by echo for LV systolic function assessment, the one you are doing in Sudan and the one you are not doing. I'm going to explain the standardized ways and measurement of LV systolic function assessment. لأنه it's good إنه أنت حتى الأشياء اللي we don't know and we don't practice, you have to know it. Okay, so you always have to be abreast of the new technologies, the new ways of doing measurement. حتى لو ما بتعملها يعني، لأنه حتى في جزء من الأشياء هنا نحن برضو we don't do them. ولكن we know إنه we are gonna incorporate this measurement in the near future. Okay, لأنه this part of echo is so dynamic target. يعني the way we are evaluating things will always be changeable. So ما في حاجة في technologies في imaging technologies will remain the same for any measurement. لأنه كل ما technology improves كل ما it will incorporate better ways of evaluation. وتقريبا ال presentation that will come in tandem with the last presentation we did together, okay, about M mode. لأنه in the M mode we also have discussed ways of assessing the LV systolic function. I will start with a bit of difficult questions, لكن don't worry about that لأنه through the discussion that comes shortly we will know the answers to all these questions. So the first question is the deformation assessment by echo. Deformation assessment is a different way of saying strain and strain rate assessment. So the deformation assessment by echo is, yes, let me mute everybody. Okay, so the deformation is another way of saying strain and strain rate. So the deformation assessment by echo is of no clinical uptake yet. So it has no clinical utility so far. Depends on the evaluation of radial vector of cardiac mechanics. And we have explained what radial contractility means last time. I'm admitting some other people. Global longitudinal strain is still in the field of research. LV is more longitudinally deformable than the RV. HFpEF has shown abnormal systolic function by strain. So if we go one by one, and if somebody courageous enough to take this one and answer or guess.
I think D is an answer.
D.
B.
Okay.
هو longitudinal
so you
strain.
think that the LV is less longitudinally deformable than the RV? That's the right answer. Because
هو عاوز الwrong ولا عاوز
the
الرايت؟
statement said the LV is more longitudinally deformable than the RV.
And this is a correct answer. It's a correct
Okay.
statement, I mean.
It's a correct statement. So, okay, keep it in mind and we will come to that later.
Maybe B. I'm thinking it's B. Depends on the
You are thinking of
radical
B.
vectors.
Okay.
I think E.
You think E.
C.
Okay.
We'll go with C also.
See, so that's great. And I think the wider the scatter, the better for me, because it tells me that after this presentation, definitely will come to select the right answer. Type, okay. The use of strain and strain rate needs. What does it need? Baseline got 2D image quality, TDI assessment of velocities, speckle tracking assessment of the myocardium, online and offline analysis, all of the above.
All of the above.
C.
All of the above. Good,
Yeah.
good.
All of the
Come
above.
on. All of the above. Good. The echo evaluation of LV systolic function. 1. Strain abnormalities precedes ejection fraction drop. Global longitudinal strain, GLS, is the most clinically validated. Is highly indicated in chemotherapy patients. Circumferential strain is a positive value. Radial strain is a positive value.
I think
Any guess?
It
You
is
think they
possible.
highly
okay?
indicated in
I'll go with
chemotherapy patients.
A.
B.
A,
A.
D. B. C.
A, B, and D, and C. So again, I
C.
have the scatter, which makes me happy to discuss this one later, and you will come to the right answer. Good. In echo evaluation of LV systolic function, which one is normal? dP over dt less than 600 millimeter mercury per second. GLS of less than 17%. EPSS of more than 14. K index of 0.5. Circumferential strain of minus 25%. So which one from these measured is is considered normal function, normal LV systolic function, or expressing normal LV systolic function? Which one?
TI index.
C.
TI index 0.5.
T index of 0.5. Okay. Of 0.5. Okay. C. EPSS of more than 14. Okay. So we'll come to that later. So now, طبعا since 2019, there was an introduction of the HIF mid-range EF. So now we are talking about 3 categories of heart failure: MREF, EEF, and REF, right? The definition of mid-range is an ejection fraction between 40 and 49%. While HIF-PIF is an ejection fraction of more than 50%, and HIF-REF is ejection fraction less than 40%. So that stresses on the importance of evaluating the ejection fraction precisely. Okay? يعني شوف the difference between 49 and 50 and 40 and 39 and stuff like that. So we have to be precise and more objective in assessing the LV systolic function than the crude way of eyeballing. Okay. Now in HIF-PIF and HIF-REF and HIF-MERF, the very first condition or the very first requirement or requisite of the classification is that you must have symptoms and or signs of heart failure. So we have to start with clinical context. We don't start from nowhere. We have to have clinical features of heart failure. Then we come to the ejection fraction and see where we stand. Less than 40 or between 40 and 50 or more than 50. Is that enough? Is the ejection fraction and the symptoms enough? No. We have to have elevated level of BMP plus one of two. One is either relevant structural heart disease or diastolic dysfunction. Okay, so in total, you need 4 parameters to diagnose PIF or mid-range EF. Symptoms, ejection fraction, high PMP, and one of two, either relevant structural heart disease or diastolic dysfunction. Okay. We have easily the value of the ejection fraction, the structural disease, and the diastolic dysfunction. So echo gives a lot of information about this classification. So probably you don't need more than echo and PMP and your clinical evaluation. That's all you need for the diagnosis of the 3 forms of heart failure. If the ejection fraction evaluated solely by the echo or the other imaging technology, they have their ways of assessing the ejection fraction. Yes, historically, the ejection fraction was assessed by angiogram. LV gram, invasive LV gram, they used to assess the ejection fraction by it. In the nuclear SPECT and PET, they have their ways from the gating images to assess the ejection fraction. Now in CT and MRI, and of course in echo. Now, if I ask you from all the imaging technology we have in our hands right now, which one is the most accurate way of assessing the ejection fraction?
MRI.
CMR.
Very good, MRI.
Yeah,
So
MRI.
MRI is considered the gold standard of volume assessment and the ejection fraction assessment. Okay, so even when we come here in the discussion shortly, I will show you how echo images, some part of echo or some aspects of echo, how it correlates to the gold standard, how it compares to the gold standard. Okay. And again, طبعا الecho, like we said last time, has come really a long way. So now we are talking about even the handheld and the mobile software you can download, and the probe you can insert in your mobile, and you can use it just like a stethoscope. So echo is going to be POCUS, which is point of care ultrasound. Is just like a clinical exam tool. Okay. طبعا that doesn't mean that echocardiographer will be out of business. No. The way echo is going to be bedside is a precise cursory way of examination. So you are going to see the LV function and the state of valve. But the sophisticated ways of assessment and the transesophageal and the stress echoes and all of this, and it's a complex hemodynamic assessment, it still needs an echo lab and echocardiographer. And of course, you have seen this one. We started with M mode, then the 2D, then the Doppler. Now we have the 3D, and we have the strain now. And sooner we are going to get the vortex. And the last part is the vortex. Okay, and this vortex technology of echo is probably the newest of all technologies, and it's going to map out the flow inside the chamber. So instead of talking about the morphology of the wall, we are talking about the morphology of the flow itself. So how the flow is mapped out inside the chamber, and that tells us about the effect of any problem. Yani in AR, how the AR translate in a flow dynamics inside the LV. That's why they call it echodynamography. Echodynamography. So this is a new way of assessing diseases by state-of-art technology, which is going to be really promising in identifying the disease entities in more deeper way. So now I'm not going to talk about mitral stenosis in area and gradient, but we'll be talking about mitral stenosis in flow map, how the map of severe mitral stenosis shows in the LV. what kind of flow dynamics we can map out in the LV with severe versus mild versus moderate. Okay, so that will take us to a different zone of conceptualizing echo diseases, and probably we're going to change our mind about severity and stuff like that. Okay, now for the assessment of LV systolic dysfunction, as I told you last time, we started by simple way of fractional shortening. And the fractional shortening is just, we need two dimensions, the LVN diastolic and the LVN systolic dimension. And we subtract the two and divide by the LVN diastolic dimension, and we get the fractional shortening. This fractional shortening is, the normal value is more than 25% for the LV. Now, this fractional shortening might be okay if you are dealing with normal and global hypokinesis. But if you are dealing with regional wall motion abnormality, it won't be accurate because the way you are taking the measurement might not represent the other segments. Okay, so you remember we talked about TAPSE and we said TAPSE is more accurate than MAPSE because TAPSE relates to the RV, and the RV most likely goes globally weak. So any segment can represent the entire segments, but that doesn't apply to the LV with its segmental problem, okay? So the fractional shortening, remember the limitation, if you are dealing with segmental wall motion abnormality, then you are not accurate. So you probably know about this one, and if you don't, you have to. And it's a fair game for exams, and I have seen it so many times cropping up in the exam. The dP over dt. dP over dt means the delta pressure over delta time. Delta pressure, meaning the change of pressure, over delta time means the change of time. So what we do here is we take the MR signal and we zoom, like if here, see, this is the MR signal, okay? We select 2 points in this MR signal. The point with a velocity of 1 and a point of a velocity of 3, okay? So 2 points across the acceleration curve. We choose 2 points at 1 and at 3. At 1, the pressure is how much? 4V1 square. So it will be 4 millimeter mercury. At 3, applying Bernoulli equation, 4V square will be 36. So I want to check the time the LV will change pressure from 4 to 36, meaning 32 change, the delta pressure 32, which is the subtraction of 2. So that's the equation here. dP over dt is 32 over the time. Now I check the time by the software this way. So if I draw it this way, it will be like this one. So I check this time. The time here, this is 1 and this is 3. 1 and 3. So I draw these two lines and I see the pressure here, the time here. So this time, now guess, the shorter this time means the better or the worse LV contractility?
The better.
Exactly.
Better.
Because
Better.
that means the LV is strong enough to change the pressure from 3 to 36 in shorter time. The longer the time, the weaker the LV. That's why from the MR signal itself, you can tell about the LV systolic function. Yani if I have an MR signal that looks like this, and I compare it with an MR signal that looks like this, the one at the bottom, the LV is weak because it takes longer time to change the pressure from 4 to 36. Okay, so this is called the dP over dt. And now let's see the normal. Normal is more than 1200. Abnormal is less than 1000. Okay. So this is the DPDT using the the MR signal, using the MR signal, and how we get to that value. Okay. Now from the M mode, you remember we talked about the morphology of the aortic valve opening and closure. And it becomes this way on the left side when we have reduced stroke volume. So when we have reduced stroke volume, there is premature closure. If you compare it to the right morphology of the M mode of the aortic valve on the right, you will see there is reduced opening and premature closure. So instead of a triangular M mode of the aortic valve, it's instead of rectangular morphology of the aortic valve M mode, now it's triangular instead. Okay, so this indicates severe LV systolic dysfunction leading to severe reduced stroke volume. Okay, and the other thing we have discussed last time is the EPSS, which is E-point septal separation. And this is the height from the peak of the E wave, or from the E, which is the anterior leaflet, to the septum. And we say that the shorter that distance, the stronger the LV systolic function. If we have weak LV systolic function leading to weak cardiac output, it will hardly open the aortic valve. So we'll find a very high distance. The shorter the distance, the better the LV contractility and the better the LV cardiac output. And we have taken the cutoff value of normal is 8, less than 8 or more than 8. So if like this one here, 14, that indicates what? Severe LV systolic dysfunction. Okay. Now you probably heard about the TAE index, and the other name is the index of myocardial performance. The TAE index is just so far used for research purposes and academia. We don't use it practically a lot, but it's still a source of questions in the exam, interviews and stuff like that, especially if you go for echo boards, you may see it. But usually it's not really practicable in reality. Lakin it's good to know about it. The TAE index is the only index in which we include systolic and diastolic function assessment in one figure. So it reflects both systolic and diastolic function in one figure. So that's the amazing part of it. How it's calculated, you see here, the mitral inflow, the LV outflow, and the mitral inflow again. So how are you going to obtain this signal? You take your cursor between the mitral and the LVO2 and you keep it in the middle. And you put on PW, or even if you put it in CW, there will be no problem. So you will capture two signals, the mitral flow signal on your right and the LVOT signal on your left. And this will depict like this one here. So between the mitral inflow and the LV flow, there is a brief empty flow period, which is isovolemic contraction time. And between the end of the LV outflow and the start of the mitral flow, there is an empty flow period, which is isovolemic relaxation time. So what is TAE index? TAE index is pre-ejection time over ejection time. Pre-ejection time meaning the time where there is no ejection and no flow, over the ejection time. So what is the pre-ejection time? It's the summation of ICT and IRT. It's the summation of isovolemic contraction plus isovolemic relaxation time over the ejection time. That gives me the index, the TAE index. How I calculate that? No problem. The easiest way is you measure all the time from this one to this one. That is A. And then you measure the time from the LV outflow beginning to the end. This type, sorry, this type. The subtraction of the two will give me the summation here. So A minus B is equal to ICT plus IRT. And I divide that by B, which is ejection time, and I get the value of the TAE index. I wish you understand it. Now the TAE index, the normal value for LV is 0.39. 0.39 plus minus 0.05. For the RV, it's 0.28 plus minus 0.04. Forget about that. Just remember 0.39 and 0.28. 0.39. Now, the bigger the value, what does that mean? If the value is 0.5, what does that mean? Is it good or bad? The bigger the value, the worse.
It is bad. It is bad.
Exactly, because the bigger the value means what? Means the ejection time is
less. Is
exactly
low. Ejection
yes,
time is low. Yes.
and the pre-ejection time is longer. So if I have longer isovolumic contraction, a longer isovolumic relaxation time, and lesser ejection time, I get more of TAE index, and that means the heart is weak because most of the time is spent in preparation, not in the actual ejection. Okay, so that's the TAE index. Now, the most commonly used, if I ask you what is the most commonly used and the most objective way of LV systolic assessment by echo, what are you going to tell me?
Simpson.
Simpson method, or by
method.
this biplane Simpson
By
method.
plane.
Exactly. So what you need here is a software. The software will use a very complex equation on the left we no echocardiologists know about. We just know that there is a complex equation used to transform what the tracing we do into volumes. And we have to have the epical, we just use it from the epical window. We need the epical 4 and the epical 2. So we measure the systolic frame in the epical window from the epical 4 chamber and the diastolic frame. And we go to the 2-chamber view and apply the same systolic frame, diastolic frame, and we get the ejection fraction expressed in volume because the equation will transfer or translate what we do by tracing into volume. So it tells us about the LV diastolic volume and the LV systolic volume. And that's what we need for the ejection fraction. Ejection fraction is LV diastolic minus LV systolic over LV diastolic volume. So that's what Simpson method does, okay? So this is the most accurate and most objective way, and most used way of LV systolic function across the board. Now, the only problem with the Simpson way of evaluation is what?
Two, either foreshortening of the LV.
Exactly.
The other one is the delineation of the inner
Very
chord of the
good.
myocardium. Yes.
Exactly. Thank you so much. So the clarity or the definition of the endocardial border, because you depends on how clear the endocardial border is. Okay, and that's why it's not always easy. Depends on the image quality, and that's why sometimes when we are so, because you know the precision of ejection fraction is not always the same. يعني مثلا الآن if I'm talking about ejection fraction of 60 or 55 or even 50 in a normal patient asymptomatic, I don't bother. لكن in a chemotherapy patient مثلا or in a severe MR when the ejection fraction is 50 is so different than 60, يعني it mark who and who will not go for surgery. I have to be precise in even 5%. The eyeballing done by echocardiologists had a variability that reach up to 10% inter-observer variability. Yani you are an echocardiologist and your colleague just beside you, you can be variable by eyeballing up to 5%. That is not good when we are talking about precision of ejection fraction, okay? We have to be more precise and more objective and more reproducible and reach the same answer. ففي حالات بنحتاج فيها نكون precise. أي نعم admittedly not all the cases لكن في cases كثيرة we have to be precise. Therefore if we lack good definition of the endocardial burden and we need to apply Simpson, we have to seek doing something, which is what? Enhancing the endocardial burden. How can? Exactly. Here comes the role of endocardial. Yes, here comes the role of contrast. Echo to delineate the endocardial border, and we can apply Simpson. And this is routine, we do it routine. I think plissal contrast يعني ما وصل السودان لكن remember إنه you can give injector contrast and you get a clear, nice delineated endocardial border from scratch, from nowhere. It was so blurred and you see nothing. With contrast, you see the endocardial border, so okay. Okay, so this is the contrast so far is used for LV opacification to delineate the endocardium. And sometimes if you have a question of a clot, a thrombus, no thrombus, you also use contrast. So these are the two main utilities of contrast echo for LV delineation, for better assessment of endocardial border ejection fraction, and for clot or thrombus. Type. Now, the other thing we assess LV systolic function with is the stroke volume. We calculate the stroke volume. Now, what is the relationship between the ejection fraction and stroke volume? Can anybody tell me? Ejection fraction and stroke volume.
It is percentage, the ejection fraction is a percentage of the volume ejected by the LV. So stroke volume divided by the...
Stroke volume divided by the end diastolic pressure will give the ejection fraction.
Exactly.
Here is the relation between the volume ejected to the end diastolic volume.
Okay. So in other words, the stroke volume is what? The stroke volume is, or the ejection fraction is the stroke volume over
The
LV
stroke volume that
over end
Over
diastolic
end
volume.
And the diastolic volume.
Exactly.
And the diastolic
Exactly.
volume.
So the ejection fraction or the ejection fraction is the percentage of the stroke volume from end diastolic volume. So they are so correlated. Good. Lakin there is a different way of assessing stroke volume that does not use Simpson. We can use Doppler. We go to the LVOT and we obtain just two measurements. That's all we need. The diameter of the LVOT and the TVI of the LVOT. And we apply an equation. You know that equation you can tell me about?
yes
Yes.
هي اللي هي هي 0.785 by D2 by
0.785
by D square by TVI.
Okay, thank you so much. So this is 0.785 times the TVI times the diameter square. You get the stroke volume. The limiting factor in this equation, which affects the accuracy really a lot, is the diameter. You have to be so accurate in diameter assessment لأنه you are going to square it. A small error are magnified by this squaring. So you have to make sure that you are doing it right. You are measuring it in the right frame. You are measuring it in the right way. Okay? وكده you get the stroke volume. Okay? Now, هل الstroke volume always correspond to the ejection fraction? In other words, يعني هل مرات if I calculate the ejection fraction by Simpson the way I do and stuff like that, and I find that the ejection fraction is 65%, my stroke volume is say 30 or 28, so it's low, ml.
Yes.
Does that make sense?
Yes. If we have low flow,
yes, thank you so much.
Volume, we are going to overestimate the ejection fraction.
Thank you so much. So this is the problem. The problem is when you see the stroke volume by Doppler, which is flow dependent, and you compare it with the ejection fraction, which is volume dependent by Simpson, there is no sharp correlation. There are so many times when the ejection fraction is low, but the stroke volume is normal, or when the ejection fraction is super normal and the stroke volume is low. And this probably explains a lot of mystery we used to puzzle in. In patient, we see so many patients, وربما انتوا شفتوا كتير. Ejection fraction حقهم say 25-30%, لكن they are doing so fine. They are living happy, normal life. Nas ejection fraction 60 and they are so extremely shortness of breath. So probably the ejection fraction does not reflect the exact functionality of the systology of the LV, and stroke volume is a better surrogate of that. لذلك measuring the stroke volume is now part and parcel of any echo routine, not only the ejection fraction. You have to count the stroke volume. وتذكروا, remember, الآن these figures are so important. Two ways of systolic stroke volume assessment. We talked about that one. Okay. We have to calculate the stroke volume by the Doppler way and the cardiac output by multiplying the stroke volume by the heart rate, and the stroke volume index, which is stroke volume divided by body surface area. And this is even more important, لأنه the index is more reflective of how low or high or normal this stroke volume according to your body surface area. يعني if you are athlete, I expect higher. If you are not, if you are slim, body surface area is low, I might accept 35-40, stuff like that. The abnormal stroke volume in terms of index is how much? Less than 35 ml per meter square. تذكروا في paradoxical AS we have discussed the very first lecture إنه paradoxical AS is normal ejection fraction لكن low gradient across the aortic valve because of low stroke volume. And how we define low stroke volume by إنه عندنا stroke volume index less than 35 ml per meter square. So we calculate the stroke volume. إذا لقيناه أقل من 35 ml per meter square, معناته this low flow across the aortic valve is erroneously low flow, and it does not reflect the severity of aortic stenosis because it's low flow. So we have to look for other measure for quantification of severity. Okay, so the stroke volume, the cardiac output, and the stroke volume index are important measurements, has to be included in echo. Okay, now one important aspect of chamber quantification is the left atrial volume. And left atrial volume can be done by two ways. Area length method, and I wish you don't know about it خلاص. يعني it's now not actually the one used. And the Simpson way, the same way, Simpson. They measure the by Simpson in the apical 4 and apical 2, and you get the volume. And again, we have the LA volume index, where we divide the volume we obtain by Simpson over the body surface area. Okay? And now the LA volume index is part and parcel of every echo. And it is so important in the guideline. They talk about diastolic dysfunction and LA index. They talk about, see, if I take you back to this one here, you remember the classification of, see, of heart failure. See additional criteria, relevant structural heart disease or diastolic dysfunction. Relevant structural heart disease like what? LVH and LA enlargement as measured by Simpson method. So LA enlargement is put in the ingredient upon which you rely on to diagnose heart failure across its different categories. So the diastolic dysfunction can be complete without LA sizing or LA volume assessment. The same for heart failure. So we have to do LA evaluation by Simpson. Okay. And you remember I have shown you this slide that the LA volume correlates so much to mortality and survival, regardless of what caused the LA dilatation. So once the LA get remodeled by whatever reason, AF, MR, MS, whatever, it leads to the same gloomy prognosis, which is this one. And that prognosis correlates so much with the degree of dilatation. So the survival correlates so much with the dilatation and with the degree of dilatation, whether mild, moderate, or severe. So that's why it's so important to define the dilatation precisely, how much of dilatation I have, because that translates in survival. Is it mild dilatation or severe or moderate? Now, the contrast echo you see on the left, now you see the images on top, how faint the endocardial border, upon which you cannot do any endocardial tracing. And you see how it becomes good here in the bottom picture. So you see the endocardial border, so nice, and you can trace it so good. So this is the utility of contrast. Now we have another way of LV systolic function evaluation, which is 3D. And by 3D, we mean we get electronic cast like the yellow one, and we see them in systole and diastole, and we get the volume. Now this is 3D volume. So it's more reflective of reality than the assumption of Simpson, okay? Because you get to the actual 3D of the heart and you check the volume in systole and diastole. So if 3D echo is the best we have so far, probably is. They have compared 3D versus 2D as compared to the MRI. And why MRI? Because MRI is our gold standard in ejection fraction. And see the difference. The graph on the left reflects the comparison between MRI ejection fraction and 2D ejection fraction, which is Simpson. And the one on the right, the ejection fraction in MRI and 3D. So the cluster is lesser with 3D, meaning the 3D is more correlating to the ejection fraction of MRI than 2D. 3D is more proximal to the figure obtained by MRI than 2D, closer to the gold standard than 2D. So 3D ejection fraction is better than 2D ejection fraction. لكن remember, that's يعني على المستوى بتاع talking about echo and stuff like that. لكن لما نيجي نقعد في اللاب no. لأنه ال 3D عندنا فيها مشكلة اللي هي الكروبينج. still الكروبينج بتاعها فيه بعض الإشكالات و need some high expertise و need some dedicated softwares. عشان كده ما recommended في guideline to replace 2D. In the future, yes. لكن so far, no. So far, we are still relying on 2D and Simpson, not on 3D. لكن هم they found that 3D correlate better than 2D للMRI. مين اللي بيعمل كده ومين اللي studies? Very dedicated, advanced, sophisticated echo labs. You cannot transfer this knowledge down across the mainstream. لسه نحن بعيدين منها. لكن التكنولوجي as it improves and it becomes more objective, more reproducible, easy accessible, ubiquitous, everybody can do it, a 3D echo ejection fraction is going to replace the 2D ejection fraction. And this is again CMR versus 3D echo, and you see the correlation. It's so nice. Okay, again, this is the same one. طيب, now I get you to the heart of the matter, and I wish I will not bore you, but this is really so important. I will touch on this topic only modestly. I'm not going to go deep, lakin I want you to know it. I want you to know it, okay? It's so important, you know. It's so important. Some of you are going to come to UK or America or in the Gulf. They will face this technology right away, so they have to know what we are talking about. So this is echo. This is the state of art echo. Everybody now, every conference you go, they are talking about strain and strain rate and deformation. So we probably have to know about that one. Now the strain and deformation imaging is now one of the emerging good ways and gonna be best ways of assessing LV systolic function. So gradually you are replacing ejection fraction by strain, gradually. So sooner you won't hear about ejection fraction as much as you are gonna hear about global longitudinal strain, GLS. So this GLS is gonna replace EF, GLS and EF, okay? So what is the strain? Strain is L minus L0 over L0, meaning what? I'm going to take a segment of the heart and I see how it deforms in contraction and relaxation. So I will take that segment and I see the initial segment, the size, and after contraction, the size. L is what? L is the final length. L0 is the initial length. Okay, so the deformability is counted as the delta change in length over the baseline length. We know that some segments contracts, some segments get lengthened, shortening and lengthening. During systole is not all shortening. Some segments are lengthening, and I'm going to show you why. So depending on that, we have positive and negative value depending on lengthening or shortening. Yani if the segment is lengthening, you expect the strain will be positive value or a negative value?
يكون positive value فكان lengthening.
Exactly.
Positive.
If it's shortening, negative value.
Negative. Yes.
Negative.
Exactly, negative value. So some of the strain is positive value, some of the strain is negative value. It depends on whether it's shortening or lengthening. That's good. Now, see here. If you take a wet towel and you want to squeeze water out of it, you are going to do compression on both ends and you are going to twist it clockwise and counterclockwise, right? One end clockwise, the other is counterclockwise. So if you squeeze water out of a wet towel this way, does the heart work the same? Yes. So they found out that the heart also has a twisting way. So the upper part twists counterclockwise and the apex clockwise. And in relaxation, the opposite happens. Okay? So the apex and base twist in opposite direction. The same way as you are squeezing a wet towel, okay? This is called twisting and twisting strain. This is one of the strains. It's not all. Strain are so many. This is one of them. Are you appreciating this movement from 2D?
No.
Never.
No.
Never. Yani if you look at the echo, you will never see that the apex and base are contracting clockwise, counterclockwise. No way to see it. No way. You see that by strain. If you depict the strain, you will see that the apex and base are rotating clockwise, counterclockwise, and vice versa. Okay, this is one strain. What about the rest? We have radial strain, circumferential strain, and longitudinal strain. The radial strain is the thickening in the short axis. Thickening. What's the meaning of thickening? معناتها it's lengthening. Lengthening معناتها positive value. So you see how the curve goes? It goes up because it's lengthening. Now the circumferential and longitudinal are shortening. That the value is negative. That's why the curve is going down below the baseline. So the radial, circumferential, and longitudinal strain are the three main strains used now. And the radial strain is of positive value and the rest are of negative value. Now, which one of these three strains is the most clinically relevant and used in clinical practice?
Longitudinal.
Which one? Longitudinal. Yes, the longitudinal strain. Exactly. So now we are talking a lot about global longitudinal strain. we don't use circumferential and radial strain a lot. لكن the one that is clinically adjudicated and found to correlate with survival and to have a clinical utility and is going to replace the ejection fraction is the global longitudinal strain. Why is that? Because they found that it reflects the systolic function better than the ejection fraction, more objective than the ejection fraction, and it drops earlier than the drop in the ejection fraction. You remember the first MCQs we have discussed. Now, if we have an LV systolic dysfunction, by GLS, we find that the GLS gets impaired way ahead of the actual ejection fraction changes. So it remains the same, the ejection fraction, but the GLS goes down, meaning that we have an actual LV systolic dysfunction that is not predicted by the ejection fraction, which remains normal. So if the GLS is more sensitive and more accurate of LV systolic function, is it gonna replace the ejection fraction? That's what we are expecting, okay? Now, according to the guidelines and recommendation, GLS should be used, or it's good to be used for patients with chemotherapy. Why? Why do you think chemotherapy is the cohort of patients most specified for the use of strain? Why?
Because it can
To
detect
predict
septal ejection systolic dysfunction. Sorry.
Exactly. ولأنه if you give chemotherapeutic agent that are cardiotoxic, you have to decide about the continuation or discontinuation according to the ejection fraction. يعني ejection fraction usually that demands discontinuation is the drop of how much? 10%, huh? 10% drop in the ejection fraction. لكن كم مرة أنا مر علي patients نقول لهم ejection fraction is 60. Now by Simpson it is 56. يعني نقص by كم؟ 4%. بالتالي carry on chemotherapy. Next cumulative dose, the patient comes to us, we check the ejection fraction is 25. What happens? حاجة غريبة. فمعناتها ال 64 أو ال 54 اللي احنا we said إنه that's what it is, قد لا تكون reflecting the actuality of the LV systolic dysfunction during that time. شوف هنا مثلا الآن this is the same as the case I'm discussing. Pre-therapy ejection fraction and 6 months into chemotherapy and 12 months into chemotherapy. Ejection fraction was 61%, bigger بعد 6 months 55%. يعني drop of how much? 6%. Will that qualify for discontinuation of chemotherapy? No. شوف ال GLS اتغير بكم؟ minus 20 to minus 17 by 15%. 15% change in GLS. So the GLS showed a more drop than the ejection fraction. So probably the GLS is more conforming to the actuality of the LV systolic function than the ejection fraction. And it reflects the subtle changes of LV systolic function much better than the ejection fraction. So هو من candidate measures for replacing the ejection fraction. Okay. Not only that, you remember سابقا يمكن انتوا لسه يعني نحن كنا بنعمل study for desynchrony by echo. يعني البيشنت قبل ما يعمل CRT للهارت فيلير and the heart failure specialist بيقولوا انه والله البيشنت ده symptomatic وعنده والله مثلا ejection fraction less than 35. We want to put an ICD CRT, resynchronization therapy. They send a patient for a special study in echo بنسميها desynchrony study. Okay? وبنعملها بالايكو. نشوف الديسينكروني. كنا بنعمل الديسينكروني بالام مود والدوبلر ونشوف الديلي in the wall systole between the anterior wall and posterior wall, septal wall, posterior wall وهكذا. عندنا our ways of doing it. من تقريبا 2010 we stopped doing it. Why? لأنه في study اسمها prospect جات طلعت قوية كده قالت إنه the mechanical desynchrony assessed by echo has not improved the selectivity of patient for CRT على الإطلاق. بالتالي stop using it. فالstudy دي sign this death certificate for echo in desynchrony assessment. بقينا من هذاك الوقت ما بنعملها. بيجوا ناس الاي بي او الالكتروفيسيولوجي they just choose patient based on symptoms, ejection fraction and ECG. Wide QRS
ECG.
complex, left bundle, they go for CRT. They don't ask us any opinion about it. Okay. ولكن do you know a CRT response rate فيه failure قدر كم؟ 30% failure. 30% failure rate.
Yes.
Okay. Not only that, ولكن لما كنا بنعمل الميكانيكال ديسينكروني باي ايكو لقوا انه 30% of patient with narrow QRS complex and mechanical desynchrony by echo respond to CRT. يبقى عندنا 30% non-responder with narrow complex and 30% non-responder with wide QRS complex. يبقى واضح جدا انه الاي سي جي alone is not gonna tell you which patient to select. يبقى you probably need echo again. ومع الاسترين الان بدوا الناس يتكلموا عن echo is going back in the business of desynchrony assessment. ليه؟ لانه بقى عندنا a better way of assessment desynchrony than what we used to have. الان شوف الكيرفز ديلا. الكيرفز ديلا are showing different contractility بين segments, and you see the behavior of the segment. When it contracts, it goes down below the baseline. The contraction, the onset of contraction, and if I show you here, sorry, that's the onset of contraction. This is the onset of contraction. This is the end of contraction. And this one is the peak of contractility. This one is the peak, this part. See, the peak of contractility is so different between the segment. Some of the segment, like the red one, is showing a complete desynchrony, meaning what? Instead of contracting and shortening and going below the baseline, it's actually lengthening. So that's a great sort of desynchrony. When you see the blue, navy blue, you see it contracts just for a very brief period and then it becomes desynchronous. So this is an initial contraction followed by desynchrony or lengthening. The other one, like the yellow one, we have initial desynchrony followed by contraction. So now we actually, even the desynchrony of the segment, we come to know that the desynchrony is much more complex than we thought it is. There is different forms of desynchrony, but we can all assess them more objectively than we used to do by this strain technology. Okay, so ده يمكن يحسن السلكتيفيتي للسي ار تي. Good. Okay. Now, the strain can also tell you about different pattern for different disease entities. الناس اللي هو كم عندهم شكل بتاع strain، ناس الفابريس disease، athlete heart، hypertensive heart، وهكذا. Okay. يعني مثلا if you look at this one here, this is the strain of a patient who has, like you see the MRI on the bottom, the left bottom. MRI is showing delayed hyperenhancement in the lateral wall and apex. When you see the lateral wall and apex by strain, you see they are of low strain and they show systolic lengthening and desynchrony and everything. So the strain is reflecting the image of the MRI really good. So it correlates so good to the MRI data. And of course, if we get echo close to MRI, خلاص يعني this is the greatest. لأنه echo is less accurate than MRI, understandably. لكن لو قربنا من ال MRI accuracy هيكون great. لأنه ال MRI مشكلته إيش؟ We cannot take it bedside. It's not ubiquitous. It's not universal. It's not everywhere. إذا عندنا technology now is as good as MRI and it can be rolled at bedside in the wards everywhere, this is a revolution. فالMRI, echo by this technology is coming proximal to the MRI data. طيب, now if I ask you, what do you think about this strain map? This is called bull's eye or polar map of the global longitudinal strain. Guess, what do you think is the problem here? Guess, just a guess.
Ischemia. I think
Ischemia.
in the lateral and inferior.
Very good. Yes.
Lateral wall.
Yes. So this is probably circ ischemia in the lateral and inferior lateral wall. Yes, exactly. Good. Now look at this thing here. Anybody can guess? The one on the left. What is the one on the left?
This is Kyria on top. This is going with the hook.
Okay, very good. So that is characteristic of cardiac amyloidosis. Okay, we call it cherry on top. Okay, which is apically sparing reduced global longitudinal strain or reduced strain. So you see the apex is of good strain while the mid and basal segment are of low strain. So this is very characteristic of amyloid. Now, what do you think about amyloid? Exactly. What about B? B is hook'em. And you see the septal, septum is low strain. You see that part? Yes. This is the asymmetrical septal hypertrophy. Now, what about C? C is the apical variant of hook'em. So this is apical hook'em. The walls are fine, but the apex is hypertrophied, and it looks like that in the strain. Now, what do you think about the last one, D?
This mid-LV hypertrophy.
Okay. Lakin why the apex is of low strain?
Apical ischemia, apical infarction.
Thank you so much. That's an apical infarction. Okay. So, يعني شوفوا الpolar map or the bull's eye of the global longitudinal strain is so representative. In just single snapshot, you can get into a great deal of information, and it reflects different patterns and different diseases. So the GLS is really comforting, and it's going to have more and more place in echo reporting. Okay. Now, probably this is the last. You remember in the first MCQs we discussed, we said HFpEF. HFpEF. And HFpEF is defined as ejection fraction more than 50%, symptoms and or sign of heart failure, and high PMP and one of two. And we discussed that. Now look at this slide. What does that tell me? The slide is showing us the longitudinal strain and the in red and the circumferential strain in green. طبعا the longitudinal strain and the circumferential strain and the radial strain, they all reflect what? LV systolic function. Now look at HFpEF and compare it with the control normal. What do you think? What do you think? Anything? يعني هنا, if you take this one,
They have reduced systolic function.
This is the normal. This is the normal. And this is the HFpEF patient with normal ejection fraction. What do we find?
Subtle systolic dysfunction.
Exactly. What's the meaning of that?
We can use it in systolic function. We can use it in the systolic dysfunction.
Exactly. يبقى لا, what's the meaning of إنه ناس الHFpEF we find إنه عندهم reduced longitudinal circumferential strain.
Longitudinal more than circumferential.
ايوه معناته عندهم ايش؟ عندهم LV systolic. عندهم LV systolic dysfunction. LV systolic dysfunction. يبقى حتى البيشنت اللي احنا we used to label as HFpEF assuming انه ما عندهم systolic dysfunction, by strain we find انه they actually have systolic dysfunction. يبقى حتى الترمينولوجي بتاع الHFpEF ممكن يتغير لانه الHFpEF is no longer a diastolic problem. Now from the strain we know that there is a systolic problem. Okay? فشفتوا الكومبلكسيتي اللي جابها السترين هيغير مفاهيم كثيره لانه الاشياء اللي احنا كنا بننظر لها باعتبار انه our fallback option او our background analysis is based on the ejection fraction, Now it's based on a better way, which is the strain and strain rate. Now this tells us a different story. You know, wallahi, what we thought about HFpEF is not as we used to. HFpEF had reduced systolic function. فالحاجات ممكن تتغير. Okay. طيب. And this is the GLS and how it correlates to survival. طبعا قبل أي حاجة يا إخوانا أي new technology أو أي new measurement تبقى of clinical utility, it has to be tested against firm outcome and backgrounds. بمعنى it's not about academia إنه we just have to do it. هل ال GLS with different figures correlate with survival and mortality? We have to have this piece of information قبل ما we إنه نقول please do GLS لأنه it's important. And this study has showed that GLS comparing less than 14 and more than 14, there is different survival rate. يبقى ال GLS alone without the ejection fraction reflects survival. But if survival طبعا is the biggest outcome, the hardest outcome we can ever probe into. يبقى if a marker or if a measure is reflecting this biggest outcome, معناته it's of clinical utility. يبقى ال GLS is not for academia and for lab interest or research interest. No, now it is reflecting an actual hard clinical outcomes. ولذلك بقى مهم في الإيكو. طيب. Now I think I will end with a bunch of MCQs, and here I want you to open your mics and answer these questions. Which one is true regarding the pulse? Pulsus alternans is called death rattle. Electrical alternance leads to beat-to-beat variation of the pulse. Pulsus deficit occurs in VTAC. Pulsus paradoxus in tamponade is due to increased blood flow to the LA in inspiration. Collapsing pulse is invariably present in severe AR. Okay, so what do you think? E.
B.
B. B. Okay. Any
B for
other
boy.
opinions?
E.
B for boy.
E.
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 Okay. So we are between B and E, right? Type. If we take E, collapsing pulse, do you think it's always present in severe AR?
No. E is
No?
wrong.
No.
It is
Type
absent
E.
in acute
It's
AR.
wrong.
Exactly. So E is wrong. طيب. We said في بعض الناس have chosen B, right? B. Look at B. Electrical alternance lead to beat variation of the pulse. You think this is right?
No.
The default
no.
alternance. No.
Exactly.
No.
This is not electrical alternance.
Yes.
Exactly. يبقى B and E
ايه هي
out.
الغلط هي الصح
A.
Exactly. Exactly. If we take C, pulsus deficit occur in VTAC, do you think that's right? No.
No.
Okay.
AF.
In AF.
AF.
Type. What about D? Pulsus paradoxus in tamponade is due to increased blood flow to LA in inspiration.
It is in expiration.
Expiration.
Exactly.
Expiration.
So the pulsus alternance, which is the beat-to-beat variation, they call it death rattle because it reflects severe LV systolic dysfunction and the poorest prognosis. Usually, the patient اللي عندهم pulsus alternance are terminal class D heart failure hooked to inotropic support and وهكذا. Okay, لذلك they call it death rattle. Right. Which of the following is true about cardiac physiology pathology? The diastolic function energy independent process. The atrial remodeling in AF leads to uniform dilatation in the 3 dimension. in the basal myocardium resides the densest adrenergic receptors. The radial motion of the myocardium is the only motion responsible for the ejection. The function of the aortic trileaflet relies on the aortic root recoil and dynamics. طبعا شفتوا في امتحان كده في بعض البورد cardiology board, they love so much this type of questions about cardiac physiology and pathophysiology. Honestly speaking, these are the toughest kind of question in the exam. Yani the clinical questions about clinical scenario and what to do are the easiest. Now, when they take you back to the basics of the physiology, oh, you get lost. It's really tough. ولذلك الأسئلة الشورت of this type are really tough. I appreciate إنه السؤال ده صعب. لكن let's go one by one. Do you think that the diastolic function is a passive process?
No, active
This is a
process.
false.
So it's exactly. So
Yeah.
now
I think the answer is E.
E. You think the answer is E, and E is the right answer. Thank you so much. You're right.
Yes.
Now, can you read B? B. Atrial remodeling in AF.
This to uniform dilatation.
ما بيكون يونيفورم دايليتيشن، بيكون يعني ما بيكون ب 3 دي، بيكون يونيفورم دايليتيشن، بيكون في ريموديلينج في الاتريال فيبريليشن.
Exactly.
فما
هي
بيحصل
3 dimension اللي احنا قاصدين، ال 3 dimension اللي احنا قاصدينها شنو؟ anterior posterior, mediolateral and inferior superior. دي 3 dimension صح؟
Yes.
A left atrium when it gets large, it usually or commonsensically it should be large in the 3 dimensions equally. ولكن لقوا إنه in one dimension is restricted. What that dimension you think is? It's the anterior posterior. Why the anterior posterior? لأنه الانتيرو posterior left atrium is restricted by the sternum and by the spine from behind. يبقى الدايمنشن ده enlargement فيه is restricted by the bone skeleton. لكن inferior superior وmediolateral is not restricted. There is soft tissue all around you, so it can dilate without any problem. لذلك you remember ان احنا عاده بالايكو we used to measure the LA size وين؟ من البارasternal long axis صح؟ من البارasternal long axis. And this is the anterior posterior. This is the dimension across which the left atrium minimally dilate. لأنه restricted anteriorly and posterior. Okay? ولذلك أحسن you measure the apical from the apical window, the anterior, the lateromedial or inferior posterior, inferior superior. ولا better still to do the volume assessment زي ما نحن قلنا. Don't rely on a single measurement. لأنه is misleading. Now, what about C? The basal myocardium, in the basal myocardium resides the densest adrenergic receptors. طبعا الادرينرجيك receptors لقوها more where
Purkinje fiber.
لا أنا قصدي الادرينرجيك receptors, the receptor for adrenaline, noradrenaline in the heart.
Conduction system AV node and SA node.
في الميوكارديوم برضه موجودة اللي هي في الابيكس موجودة أكثر. And that's why the theory of Takotsubo اللي هو stress induced cardiomyopathy, because there is maximum stress and there is a surge of adrenaline, it affects the adrenergic receptor in the apex and leads to ballooning of the apex while sparing the base and mid. Okay? لأنه الأبيكس فيه the densest adrenergic receptors. Okay. Now, what about D? The radial motion of the heart is the only motion responsible, and now we know. Now, I want you, after the end of this lecture, you all go around talking about radial strain, circumferential strain, longitudinal strain, and twisting strain. So these are the 4 strain everybody is talking about. حتى لو عرفتوها as names, that's enough. But we have to know إنه That radial contraction, which we check by echo as ejection fraction, is just one part of a complex set of cardiac mechanics. That's enough for me, okay? Type. Now, what about this one? What other features in echo for this patient you will be on the lookout for? I will bring it closer, zooming in. So what is this? You can see what's going on here. You have a spirometer and you have hepatic venous Doppler. So what did you see?
We have a reversal flow during expiration in the hepatic vein.
During expiration, increasing or increasing during expiration?
Yes, reversal flow.
مع الانسبيريشن بيقل الفورورد.
Exactly.
ايوه بيقل الفورورد.
طيب ده inspiration. This part is inspiration. Look at the inspiration flow. Slow, right? Look at the expiration, this part, and this is the flow. So the flow increase in expiration. What's that?
Constriction.
Yes, this is constriction. Very good. This is constriction. So if this is constriction, which one are you going to look for here? Severe TR, pulmonary hypertension, LV thickness, septal shatter, or precardial effusion. The septal shatter, this is the septal shatter and bounce and stuff like that. Okay, good. Now, sorry, but this is an important MCQs for me. طبعا هنا نحن عندنا في الإكزام جزء من الإكزام دائما عن الميديكال ethics and research دائما بيكون فيه. Which of the following statement pertinent to medical ethics and conduct is false? The physician has a moral obligation to report poor, bad doctors to the concerned medical administration. ما في سوداني بيعمل كده صح؟ ما في سوداني بيعمل كده. لكن by the way, that's what you should do, okay? يعني دي نحن عندنا في السودان big mouth. حتى تعلمنا من نحن أطفال don't ever snitch on your friends ولا ما في طريقة تعمل كده. ولكن this is we should. أيوة نعم. The DNR decision should not mandate the family consent. يعني DNR, patient DNR.
Right. This is right.
This is right. Family has nothing to do with this decision. It's purely medical. They can be informed courteously, لكن their decision or their contribution not important. Now, physician may, in exceptional situation, have to place the interest of others above those of the patient.
No.
Wrong.
Never.
Not never. Not
طيب ما
never.
هو قال
Sometimes maybe unconscious.
مثلا هنا may in exceptional situation. يعني الآن أنت can you breach confidentiality? Can you? Yes,
No.
you can.
Yes.
No, you can. You can.
No.
You are allowed to breach confidentiality in special circumstances. Now,
أيوة إذا
breaching the
كان هو
confidentiality, exactly. Breaching the confidentiality is against the patient interest, لكن you are doing it for the public interest
Safety.
مثلا. Huh?
For safety مثلا.
For safety, for public interest, notification about infectious disease, notification about HIV to his wife, and all of these things, okay? So you may, yes. Mutual decision-making between the patient and the physician has to replace the paternalistic approach to decision-making.
Yes.
Yes, طبعا. Paternalistic يعني نحن we are no longer parent-like instructing kids to do and not to do. It's a bilateral discussion, okay? The physician will be held accountable if he violated the guidelines recommendation in the management and that has resulted in damage.
False.
False. Explain.
because
Explain.
the guideline sometimes may
لما
not
خلاص
be
حتكون
obligatory.
خلاص دي
يعني it guide you but sometimes it not obligate you يعني.
Yes.
لا
صحيح. فأنت هنا it's not about violating the guidelines because you have a room to violate the guidelines. حتى الجايدلاينز تحت مكتوب فيها disclaimer إنه these guidelines are meant for being just general recommendation, are not meant to be followed religiously. You are free upon your discretion to decide about the patient according to your the expertise of the center and the setup and the patient individual context. No. يبقى there is a margin of your own judge and freedom. Okay, it's not guidelines يعني نحن ما robotic to take the guidelines and just do it this way. يبقى violating the guidelines is not a problem. المشكلة if you violate the guidelines, you create damage and that damage is causally linked to what you have done. وجاء eyewitness قال what you have done is wrong. هنا انت you are liable. يبقى بالمحاكم عادة ما في محكمة لا هنا لا في أمريكا بيجيبوا الجايد لاينز لما يحصل دامج بيجيبوا الجايد لاينز يقولوا you have done right ولا you have done wrong according to these guidelines. No, what they do is they ask us وكثير they call us for مثلا court somewhere بيجيبوا eyewitness أو expert witness. يعني مثلا interventional case حصل فيها غلط يجيبوا interventionalist يجي في المحاكمة دي يجيبوه كإكسبيرت ويتنس يقولوا له يا أخي this physician has done this one. What do you think about what he has done? Is it wrong or right according to this clinical scenario? Expert witness account or testimony is make or break for the case. يعني إذا قال it's okay, yeah, and I would have done the same, خلاص, finish. إذا قال no, this is wrong, oh, finish. يبقى it's not about the guidelines, ولكن it's about expert witness testimony. And it's not about violating the guidelines على الإطلاق. You are free to violate as much guideline as you can. ما فيها مشكلة. لذلك, which one here the best describe the exact value and the use of guidelines in medical practice? Which one? To dictate the practice through unbreachable rules? Of course, wrong. To provide legal coverage for physician. What do you think about this one? Legal coverage for physician.
No.
لأنه زي ما قلت لك في أي محكمة ما بيجيبوا الجايد لاينز ولا أي حاجة. ما عندهم علاقة بدي. To serve the best interest of the patient.
Okay.
Or to benchmark the clinical practice. Or to standardize and legitimize the clinical practice.
E.
ها؟
Standardize the clinical practice.
بس المشكلة في شنو؟ فيها two words فيهم مشكلة. أيوة legitimize معناتها it's legally backing, which we said no. لكن to standardize is to benchmark the clinical practice, which is the right thing. We need to standardize the clinical practice so a cardiologist in Sudan is talking the same language as a cardiologist in Europe and America. We know the same and we do the same. And our experiences share the same way with the same language, with the same tracks and tools. That's what. برضو حاجة مهمة للguidelines is medical insurance. Medical insurance is stick to guidelines so religiously. Okay. فدي الحاجات المهمة يعني. ولكن الباقي is not right. Yes. طيب PMB, pro-PMB are important prognostic markers. Which of the following statement is not true as to their dynamic and utility? Is not true, false. High level in acute coronary syndrome is prognostic. True. Higher level,
True.
yes, very good. Higher level is expected in HFrEF than HFpEF.
True.
No, I don't think so.
يعني الآن إذا patient عنده ejection fraction 20 و patient ejection fraction 60 and both have heart failure, which one will have higher PMP?
HFrEF most likely.
exactly. يبقى B is right. Higher level is expected. لا صح. Higher level is expected in reduced ejection fraction than preserved ejection fraction. لأنه with reduced ejection fraction you have chamber enlargement and more strain. Higher level is expected in heart failure due to constrictive pericarditis than restrictive. Sorry, this is a mistake here. Higher level is expected in restrictive than constrictive. What do you think about this one?
Right, restrictive.
إذا مسكنا constriction and restriction, which one you think the BMB is higher in?
Restrictive.
Restrictive. Why
Muscle.
not high in constriction?
Muscle disease.
Why not?
Muscle
Exactly.
Muscle.
One, because it's muscle disease. Two, because the stretch.
more
the
atrial dilatation.
ايوه الاسترتش بيحصل اكتر وين؟ الميوكارديال سترين بيحصل اكتر وين؟ في الريستريكشن ولا في الريستريكشن؟ لانه الكونستريكشن the heart is compressed from outside. ما بيتمدد كويس، ما بيحصل فيه stretch. Exactly. طيب BMP trial have proven their utility to distinguish between cardiac dyspnea versus non-cardiac dyspnea. أول trial كان اسمها BMP breathing not properly. وشافوا ال BMP and how it behaves in pulmonology and cardiac diseases ولقوها الآن is so good. يعني البيشنت إذا جاء shortness of breath ولقيته high most likely it's cardiac than lung. Okay.
Yes.
Sacubitril decreases the catabolism of PMP.
Wrong. It is the catabolism of A and B.
Increase.
It's true لأنه عشان كده إحنا البي إم بي ما بنستخدمه في الهارت فيلير لو العيان بياخذ ساكروبيتريل.
أيوة صح. لكن هل increase ولا decrease؟
This is wrong.
Decrease the catabolism. No?
Increase the catabolism.
Decrease the catabolism.
المفروض إنه بيزيد الليفل of PMP.
عشان كده الليفل حقه بيكون عالي لكن ما due to heart failure. This is due to the drug.
I agree with you. هو طبعا الساكيوبيتريل is one part of which drug؟ الأرني. Angiotensin receptor neprilysin inhibitor. What is neprilysin inhibitor? Is sacubitril. Exactly. So sacubitril inhibit the neprilysin. What is the neprilysin? Neprilysin breaks the BMP. يبقى sacubitril inhibit the breaker of the BMP. بالتالي بيعمل شنو؟ It decreases the catabolism of BMP. It decreases the catabolism. Okay? So E is right. لأنه الساكيوبيتريل اللي هو الانترستو الدرج الكامل الفانكشن الأساسية حقته إنه we need to elevate the level of BMP.
Yes.
Okay? Through decreasing the catabolism of BMP. Through inhibition of neprilysin by sacubitril. Okay? طيب last one.
So D is false.
لا E is right. The only right is E. All the rest are false. Okay. A heated debate arose between the cardiologist and ER physician over the possible etiology of elevated troponin in a patient who came in with severe UTI accompanied by pyrexia and tachycardia. The cardiologist claimed it was non-cardiac troponin, while the ER physician insisted the heart must have a serious problem. Which side in the argument will you take? The cardiologist من باب التحيز كده يعني ولا the ER physician? None, both, or you prefer to be a fence-sitter? In this argument, I really don't know. So which one you think is right? بالمناسبة this scenario is so common and I don't know if you are confronted with this one. يعني دايما الناس ER والميديسين وكده whenever they get high troponin خلاص they shut down everything else, analysis come to an abrupt halt, cardiologist must take over. ينادوك
تحيزا كده مع
whatever.
الكاتب.
cardiologist.
The cardiologist is right.
The cardiologist هو مشكلته قال ايش؟ شوف الكارديولوجيست قال شنو. The cardiologist claimed it was non-cardiac troponin. Is there any such as non-cardiac troponin?
No.
No, صح. يبقى العبارة اللي يفترض كان يقولها صح ايش هي؟
It is non-ischemic troponin leak.
Very good. This is non-ischemic troponin release. So the heart is affected. Yes, the ER physician is partially right. لأنه قال the heart must be affected. Yes, it must be affected. لكن not due to ischemia or any correctable condition that relates to the heart itself. It's because of the sepsis. Sepsis has affected the heart and the heart has leaked troponin. Okay? يبقى we shouldn't say إنه this is non-cardiac troponin. We better to say non-ischemia related troponin or sepsis related myocarditis troponin. Whatever you can say. Okay? And that's it. And طيب, the last one, what do you think here? Hookam, viral myocarditis, constrictive pericarditis, amyloidosis, or ischemic cardiomyopathy?
Hookam.
Amyloidosis.
Amyloidosis. Why amyloidosis?
The myocardium in the 2D is thickened and sparkling.
أيوة يعني ممكن نقول هنا the sparkling texture and the small rim of pericardial effusion and the low voltage in the ECG, right?
Well, I think amyloidosis is because of a diffuse subendocardial enhancement.
Thank you so much. طبعا this is
low
the
voltage,
most
low voltage.
No
amplitude in the ECG.
Yeah, هي كلها right. Sparkling texture, small rim of pericardial effusion, low voltage ECG. ولكن the most important image is this one. اللي هي this is global subendocardial enhancement by MRI, which is diagnostic of cardiac amyloidosis. This is diagnostic of cardiac amyloidosis. يعني من ال ECG alone, you cannot clutch the diagnosis confidently. You can suspect it, لكن the final verdict is by MRI. Okay? This is the MRI. So thank you so much. I think that's it. وشكرا جزيلا لكم جميعا. Thank you. Thank you so much.
شكرا لك دكتور حاتم.
يعطيكم العافية إن شاء الله. الله يسلمكم إن شاء الله. يلا نلتقيكم يوم السبت مع دكتور رشيد and transophageal echo.
إن شاء الله.
يلا في أمان الله. شكرا لكم
في
جميعا.
أمان الله.
جزاك الله خير. شكرا جزيلا.